there are more than one. There is more than one type of cauda equina, or one classification, is there not?
There are, and the classifications are a little bit academic, but they're important to know, because if you're going to use terminology when you're talking about a potential referral, I think it's helpful to have an idea of what kind of classifications there are, but also it gives you an interesting insight into the timeline and how cauda equina develops as a syndrome.
Right.
So the first of these classifications is what we call suspected cauda equina, CESS, and we'll come on to the definition of each of those in a minute. Then you have early cauda equina, incomplete, cauda equina with retention, and then complete cauda equina. So suspected cauda equina is when there are no bladder, bowel, sexual, saddle anesthesia symptoms, but the patient does have bilateral sciatica with or without motor or sensory loss in the legs. Or you know from an MRI scan that there's a large central disc herniation.
So just to confirm, BBSA, bowel, bladder, and sexual
saddle anesthesia.
Saddle anesthesia,
yeah.
Right? Okay.
So we talk about sexual dysfunction in cauda equina as well. It's quite a difficult area, partly because most people who have got that much pain are not sexually active. So it's not a particularly helpful question, although it's an important one to ask. But also because people don't generally answer the question as accurately and honestly as they might do. But certainly if a patient presents with no bladder, bowel, saddle anesthesia symptoms, but they do have either bilateral sciatica or motor sensory loss in the legs, and or they have a known large disc herniation, the important part there is that it's a large disc herniation, then we should have a potential diagnosis of suspected cauda equina.
Are you bothered about how far down the legs these symptoms extend? Or if it's bilateral, it's bilateral, and let's get it sorted.
I think that would be enough for me. If it was going to the knees or below the knees, I would be concerned enough to be looking to do something about it. I mean, in theory, ridiculous symptoms should travel the full length of the nerve path. But anybody who thinks they know exactly how nerves behave is either misguided or naive, because nerves can behave in really peculiar ways, where pain can jump from one part of the leg to the other and miss out a section of leg. It can jump from one leg to the other. It can affect both legs or neither leg. So we shouldn't be too certain about what we're talking about if it only travels through part of the leg and not the entire leg.
Yeah. So often the knee is the marker for things, isn't it? That's when we start getting concerned.
Yeah, and I think the nature of the pain is also a big indicator. Neurological pain, radicular pain, is unlike any other pain.
Yes.
Yeah.
We've all seen that.
Referring pain from muscle pain or a joint pain it can be very uncomfortable, but neurological, nerve compression pain makes people cry, and that's a strong indicator of what you're dealing with.
Yeah. Okay. So that's our suspected one. Then we've got enough to make us wonder.
And then we have early cauda equina, where essentially there is normal bladder, bowel, and sexual function, but there is some sensory loss in the perineum, or early changes in initiating micturition, so initiating peeing. So again, your index for suspicion starts to rise. You're going from a suspected cauda equina to something that you now think is the very early signs. And that's why whenever somebody comes in with what you think is a disc problem, with some ridiculous symptoms, it's always worth asking about bladder and bowel. Does it feel normal for you? And particularly if the symptoms are starting to develop in terms of, I go for a wee, I stand or sit there for a little while before anything happens, and then eventually I start to get a trickle. You should start to think about whether that's an early sign of cauda equina syndrome.
As opposed to at my age, where I'm just wondering why I'm there.
And that's, but that is a very valid point. Is that when particularly men get to a certain age, the prostate becomes a bit of a problem, and then initiating micturition can be an issue anyway. But that would be relatively normal for that person. They would have a months or year-long history of struggling to initiate peeing. But if it's something that's suddenly happened in the last week or two, and is concurrent with their onset of their back problem.
And either way, you want it investigated if it's a recent.
Yes, unless they have a known benign prostatic hypertrophy, but it's been going on for ages and ages, and that is just normal for them to stand there for a little while thinking about it before anything happens.